Medicine can look complicated until you can see it. Welcome to StepTune. Learn medicine, visualize success.
We're targeting exactly what you need to know to absolutely crush your NBME exams by decoding the mechanisms behind the medicine. Moving right along to Section 2, Respiratory Rescue and Control. Let's look at our first drug, dextromethorphan. If you're reading a clinical vignette about a kid with a dry, non-productive cough after a viral infection, you should immediately be thinking of dextromethorphan. Just picture the mnemonic. Dex is a kid orphan who wears a mask to suppress that cough reflex. It acts centrally without causing respiratory depression at normal doses, which is great. But high-yield warning here. At high doses, it acts as an NMDA receptor antagonist, so it definitely carries abuse potential. Oh, and absolutely watch out for serotonin syndrome if your patient is taking an MAOI. Now here is a classic exam trap pulled straight from the raw notes. The professor's cue might say something simple like, Montelukast decreases basophils. Okay, stop right there. Do not simply memorize that. If you do, you're going to totally miss the question when the test makers actually ask for the definitive mechanism of action. The exam quality reality you need to know is that Montelukast is a prophylactic controller drug that blocks cis-LT1 receptors. By doing this, it specifically prevents the effects of LTC4, LTD4, and LTE4. This completely halts leukotriene-mediated bronchoconstriction, airway edema, and mucus production. You use this for asthma maintenance and aspirin-exacerbated respiratory disease. It is not a rescue inhaler. Remember that. Speaking of rescue, when a patient has an acute asthma attack, we're reaching for albuterol. And you have got to know this second messenger signaling pathway absolutely cold. Albuterol hits the beta-2 receptor, which activates GS. That upregulates adenylyl cyclase, ultimately leading to a big spike in CAMP. And it's that increased CAMP that pops the airway open. Quick side note though, beta-2 stimulation drives potassium into cells, so always be on the lookout for hypokalemia and tremors. So we really need to contrast this acute rescue pathway with chronic control. Albuterol acts on a membrane receptor for a super rapid acute response. Beclomethasone, on the other hand, is an inhaled corticosteroid, and it doesn't use a rapid membrane receptor at all. Instead, it actually crosses the cell membrane, binds to an intracellular glucocorticoid receptor, moves right into the nucleus, and alters gene transcription to suppress inflammation. It's fast versus slow, membrane versus intracellular. Make sure you keep those straight. But listen, chronic control definitely has a cost. You need to be aware that local glucocorticoids suppress immune function in the mouth and throat. And this local immunosuppression is what allows candida to overgrow, giving you oral thrush. So what's the immediate clinical application here? The patient literally must rinse their mouth out after using this inhaler. If a vignette shows you an asthmatic patient with white plaques in their mouth, boom, you instantly know it's beclomethasone. All right, on to Section 3, pulmonary fibrosis and sedation. Let's take a look at a classic oncology drug that has a pretty devastating respiratory side effect, bleomycin. Just remember the mnemonic, bleo blows the lungs. It causes free radical formation that results in actual DNA strand breaks. The clinical manifestation you have got to watch for on pulmonary function tests is restrictive lung disease. And remember what that means, a decreased total lung capacity, but crucially, a normal or even increased FEV1 to FVC ratio. Shifting gears over to sedation, let's talk about midazolam, which is your classic benzodiazepine. It acts on GABA-A receptors. Now, exams absolutely love to test if you know the exact mechanism difference between benzos and barbiturates. Benzos, like midazolam, increase the frequency of the chloride channel opening. Barbiturates increase the duration. Frequency versus duration. Mix those two up and you just threw away an easy point. So imagine this. What happens if your patient becomes excessively sedated while on midazolam? The answer you're looking for is flumazenol. It's a competitive antagonist right at the benzo binding site, but you have to be incredibly careful here. While it absolutely reverses the sedation, giving flumazenol can precipitate violent seizures in patients who are dependent on benzodiazepines. So yes, it's a lifesaver, but it requires some serious caution. Let's move down to Section 4, GI motility and toxicity. Picture a patient with long-standing diabetes who comes into your clinic complaining of early satiety and nausea. Because of their autonomic neuropathy, their stomach just isn't emptying properly. This is diabetic gastroparesis. You're going to want to use metoclopramide to increase that gastric emptying. But how is it doing that? Well, it's a D2 receptor antagonist, and because it's blocking dopamine, you absolutely must watch out for extrapyramidal symptoms, or EPS, things like acute dystonia and tardive dyskinesia, as well as hyperprolactinemia. Okay, pay attention because here is a massive gotcha framing from the professor's notes. The raw notes literally say that lactulose increases ammonia absorption for hepatic encephalopathy. Let me tell you, if you read that and take it as gospel, you'll get the physiology completely backwards on test day. Here is the actual reality. Lactulose decreases ammonia absorption. It's so important to understand why. Gut bacteria metabolize the lactulose and create an acidic environment. This acid takes absorbable ammonia, which is NH3, and turns it into a charged ammonium ion NH4+. Because it has that charge, it can't cross the membrane anymore. It just gets trapped right there in the stool and is excreted. Just remember the phrase, lactulose locks ammonia in the colon. Now, for severe visceral pain, like what you'd see with biliary colic, opioids like morphine are often the go-to. But you need to know the intracellular signaling here. Morphine acts as a mu-opioid agonist via GI pathways, and that leads to a decrease in CAMP. Simple enough, right? But whatever you do, don't forget the classic side effect cluster that the NBME is inevitably going to test you on: respiratory depression, meiosis, those pinpoint pupils, and profound constipation. All right, we've made it to Section 5, the ultimate mechanism map. By organizing your knowledge side by side like this, you completely change the game. Matching the drug to the exact receptor target and the precise signaling result is how you shift from being just a rote memorizer to an absolute master of the material. You can clearly see how albuterol's GS pathway creates CAMP, while montelukast blocks the cis-LT1 receptor entirely. You see midazolam increasing channel frequency and metoclopramide blocking dopamine. Building this kind of mental framework is your anchor for exam day. Here is your rapid-fire payoff. These are the absolute top 10 things you need to memorize cold from Part 1 before walking into that exam room. Ready? Albuterol to CAMP, montelukast for cis-LT1 prevention, inhaled steroids for chronic control but watch out for oral thrush, bleomycin blows the lungs with fibrosis, reverse midalam with flumazenil, metoclopramide blocks D2 but can cause EPS, lactulose traps NH4+, and systemic steroids carry a serious immunosuppression risk. Drill these into your head. I'm going to leave you with this crucial connection to think about. If local steroids cause local problems like oral thrush, what do you think happens systemically? Well, systemic, prolonged immune suppression can actually reactivate latent tuberculosis. It's all connected, like a giant puzzle. Keep linking those concepts together, stay focused on the mechanisms, and I will see you